Dear colleagues in cardiology and electrophysiology, welcome back to our module of 100 golden rules in supraventricular tachycardia. Today I'm going to discuss tachycardia induction and how can we assess and interpret the tachycardia in appropriate way. So let's start our lecture today. As we know, the aim of tachycardia analysis and assessment is to differentiate from the most common three types of SVT: AVNRT, AVRT, accessory pathway mediated tachycardia, and atrial tachycardia. And we have to assess and answer 6 questions in which it will guide us so much to reach our diagnosis. Number 1, what is the relation between ventricle and the atrium? VA relationship, is it one-to-one conduction or dissociated? Number 2, what is the atrial activation sequence? Is it eccentric or concentric? Number 3, VA interval, is it long RB, short RB tachycardia? VA interval less than 70 milliseconds or more. Number 4, initiation, termination of tachycardia. How does tachycardia start? How does it terminate? Number 5, a change in intervals and wobble of tachycardia. HH interval start to change or AA interval? Finally, is there any evidence of increase in VA time with functional bundle branch block or not? Let's start with the first question, and we have amazing golden rule. VA relationship. If V is equal A, it may be AVNRT, atrial tachycardia with one-to-one conduction, accessory pathway mediated tachycardia, AVRT. If V is more than A, maybe junctional tachycardia, AVNRT with upper common pathway block, or uncommon accessory pathway, which is nodovascular or nodoventricular accessory pathway. If A is more than V, it may be atrial tachycardia 2-to-1, 3-to-1, or atrial flutter. Unlikely AVNRT with lower common pathway. This is the general golden rule that we have to discuss. The main issue, the concept is what structures are necessary for SVT. We have to know this very well. In atrial tachycardia, impulse come from atrial focus, then go down AV node, reach ventricle. So atrium is the main part of tachycardia. AV node is not a part or ventricle, it's only atrium. In AVNRT, impulse go down slow pathway, retrograde fast pathway. So we may miss atrium or ventricle. That's why AVNRT may be one-to-one, as we know, or may be dissociated, A more than V or V more than A. What about accessory pathway mediated tachycardia? The circuit include atrium, the impulse come, go down AV node, reach ventricle, then retrograde through accessory pathway and reach atrium. So all these are integral part of the circuit: atrium, AV node, ventricle, accessory pathway. So in all cases of accessory pathway, it's one-to-one conduction, and we can't miss V or A. This is the main concept. So let's have an example in which we have A more than V. It's a 2-to-1 conduction. So it's SVT, narrow complex tachycardia. A is more than V. In this example, it's AVNRT with lower common pathway block. Still, we have other differential diagnosis by EB study we can reach. Next golden rule of SVT assessment, which is atrial activation sequence. If it's a concentric, AVNRT is likely, or AVRT using septal accessory pathway or septal atrial tachycardia. Eccentric atrial activation, retrograde earliest A may be distal CS or high right atrium. Eccentric activation, AVRT is likely using lateral accessory pathway or atrial tachycardia. AV-NRT is unlikely. So to understand this, we have retrograde conduction from the ventricle. In the left panel we have concentric activation, which is nodal conduction in AV-NRT, or maybe septal accessory pathway or septal tachycardia. On the right panel it's eccentric using accessory pathway, left lateral accessory pathway, so it is extranodal conduction. Here we have an example. Let's assess atrial activation sequence. On the left side of the tracing it's ventricular pacing, and we can appreciate the earliest atrial activation at the high right atrium. So we have right lateral accessory pathway. After stopping the ventricular pacing, tachycardia continued, and we can assess narrow complex tachycardia 1-to-1 conduction with earliest atrial activation at distal CS1-2. So it confirms presence of left lateral accessory pathway. So this patient has right and left accessory pathways. Let's go to next golden rule to assess SVT. How is VA interval? Is it long RB or short RB tachycardia? Short RB tachycardia, RB is shorter than BR. It may be BR interval 70 milliseconds or less, or maybe longer. On the other side, long RB tachycardia, RB is longer than BR. Let's go to more details to understand this amazing golden rule. So in short RB tachycardia, RB is shorter than BR interval. If RB is less than 70 milliseconds, the most common scenario is atypical AV-NRT, slow fast type, or junctional tachycardia, and sometimes atrial tach with first degree heart block. BR interval is prolonged. If RB is more than 70 milliseconds in short RB tachycardia, AVRT accessory pathway is likely. However, it may be atypical AV-NRT, slow, or atrial tachycardia. If it's long RB tachycardia, we have differential diagnosis. The most common scenario is atrial tachycardia. However, still BGRT, atypical accessory pathway may be optional, or atypical AV-NRT fast slow. Let's go in depth. When we have short RB tachycardia, VA time shorter than AV, RB shorter than BR, it means we have maybe AVRT or AV-NRT. On the left hand, we have an example of accessory pathway, short RB tachycardia and RB more than 70 milliseconds. Let's try to understand the impulse in orthodromic go down AV node, then his bundle ventricle, then start the retrograde conduction through the accessory pathway with fast conduction. That's why the VA interval is short using fast conducting pathway. However, the VA time is more than 70 milliseconds. On the right hand is AV-NRT, in which the impulse go down slow pathway, retrograde fast pathway, and retrograde conduction through the fast pathway. In sometimes the atrium and the ventricle simultaneously in parallel activation. That's why it's short RB. VA time is very short, less than 70 milliseconds. Let's go to long RB tachycardia, and as we mentioned, atrial tachycardia is the most common scenario because the impulse comes from atrium, down AV node, ventricular activation, then wait for the new atrial focus to fire a new impulse and go again and continue the tachycardia. It's a long VA time. Second option is atypical accessory pathway in pediatric called the permanent junctional reciprocating tachycardia. It is right postuseptal accessory pathway, slowly conducting decremental, one of the exceptional scenario of accessory pathway with decremental conduction. So we can appreciate antegrade conduction AV node, retrograde through the accessory pathway. That's why VA time is very long, as it is decremental conduction. Last example of long RB, atypical AVNRT. Impulse go down fast, retrograde slow. Let's have an example for tachycardia 1-to-1 conduction, and the VA time is about 70-80 milliseconds. So it's the short RB tachycardia with VA interval more than 70. It is an example of typical accessory pathway AVRT. Golden rule in SCVT: if we have VA less than 70 milliseconds, AVRT is impossible, we can exclude. If VA more than 70 milliseconds, all options are there: AVRT, atypical AVNRT, or atrial tachycardia. Number 4 in SCVT assessment, termination, initiation of tachycardia. And this question is very important. How does tachycardia terminate and end? In AVNRT, it may be by A or V. AVRT, A or V. In atrial tachycardia, termination with A is impossible. Let's try to understand the concept. In AVNRT and the AVRT, it's AV nodal dependent. So termination by tachycardia may be due to block in AV node. It makes sense. So it may terminate in AVNRT with block in slow pathway or fast pathway. So it may be V or A. Again in AVRT, impulse go down AV node, retrograde accessory pathway, termination may be A and may be V. In atrial tach, it's a different story, as atrial tach not dependent on AV node at all. So termination of atrial focus mean the last atrial beat will go down through AV node and lead to ventricular activation. That's why termination of atrial tachycardia be impossible with A, usually V. This is an example of accessory pathway tachycardia, termination with A. It makes sense, and it's impossible to be atrial tachycardia. Golden rule: termination of tachycardia with A, atrial tach, is excluded 100% because it is not dependent on AV node. Let's go to initiation of tachycardia. How does SCVT start? In AVNRT, we know about dual AV nodal physiology when we give premature atrial complex. At that time, fast pathway in refractory period, so it will jump from fast pathway to slow pathway, AH jump, then initiation of tachycardia. In accessory pathway, atrial pacing lead to accessory pathway, reach refractory period, loss of pre-excitation, initiation of AVRT, antegrade AV node, retrograde accessory pathway. What about atrial tach? Start with premature atrial complex, different B wave morphology and axis, and the initiation of atrial tach. And we know the concept of everyone: AVNRT, go down slow, retrograde fast. In AVRT, giving extra stimulus or atrial pacing, block the accessory pathway, initiation of AVRT, antegrade AV node, retrograde accessory pathway. And in atrial tach, it's different B wave morphology from different atrial focus away from SA node. Now let's see, this is initiation of tachycardia at the right side of the tracing. 1-to-1 conduction looks short RB tachycardia, but let's see when we start with atrial pacing S1, then give early SC2 with short coupling interval. What happened? This is the cornerstone, this is the key. Initiate tachycardia, in which we can appreciate long BR interval and long AH interval. It's AH jump lead to initiation of AVNRT. What about this example? It is looks short RB tachycardia, VA time 70-80 milliseconds. However, we start atrial pacing, there is clear evidence of pre-excitation, then give SC2 with short coupling interval lead to sudden loss of pre-excitation. Accessory pathway is no longer conduct antegrade conduction in ERB now, so the impulse will go antegrade AV node retrograde accessory pathway, initiation of AVRT. Finally, this is the atrial tachycardia initiation with multiple BACs, different B wave morphology lead to long RB tachycardia. Let's go point number 5 in assessment of SVT, in which we can appreciate a change in intervals and wobble in tachycardia cycle length. This is a golden rule that we have to focus about. Spontaneous a change in tachycardia cycle length during SVT. If HH a change precede and predict AA interval, it means it's AVRT or AVNRT. It's likely because it's AV nodal dependent. That's why HH interval a change precede. On the other side, if AA interval change precede predict HH interval, it means it's atrial tachycardia. Why? Because it is non-AV nodal dependent. A golden rule. This is an example. Tachycardia initiation of 1-to-1 conduction of SVT. But we can see intervals it change every cycle length, and we can appreciate AA interval change start to it change, and it is predict and precede HH. What does it mean? It is atrial tachycardia, non-AV nodal dependent. On this example, HH interval change precede and predict AA interval. What does it mean? It's his dependent, AV nodal dependent. So it may be AVNRT or accessory pathway. This is an example of accessory pathway orthodromic and sudden termination of AVRT. How we know? Terminate in A, so atrial tachycardia is impossible. What else? HH interval change precede AA interval. Finally, the VA time is fixed. So I am dealing with accessory pathway mediated tachycardia, and the atrial tachycardia is impossible. Let's go to another golden rule, spontaneous change in tachycardia cycle length in SVT. If you find all intervals it change, but fixed AA interval and all other remaining intervals it change, it means atrial tachycardia is likely. On the other side, if the tachycardia has fixed HH interval and all remaining intervals it change, it may be junction tachycardia and occasionally AVNRT. And this is example of wobble in tachycardia, in which we can see atrial cycle length fixed and HV interval it change in all cycle length. So what does it mean? Fixed atrial cycle length. It means we are dealing with fixed atrial focus. It's atrial tachycardia. And this the other side, we can appreciate a change and wobble in tachycardia cycle length, but HH intervals are fixed 295 and a change in remaining AH, HV, VA, everything is changing. So it may be junctional tachycardia or atypical AVNRT, because in this example it's long RB tachycardia, and actually this is a case of atypical AVNRT with constant HH interval, and there is oscillation in atrium ventricle variable VA AV time but fixed HH interval. An amazing golden rule: if we have spontaneous change in tachycardia cycle length with fixed VA interval, atrial tachycardia is excluded 100%. Why? Let's get the concept. Because in the case of orthodromic accessory pathway, the impulse go from atrium to ventricle, AV node, retrograde conduction accessory pathway. So VA interval is fixed. In AVNRT, antegrade slow, retrograde fast pathway. So VA time is fixed, But in atrial tachycardia, it's a different story. Why? Because the impulse will go AV node, ventricular activation, then we have to wait for the next atrial focus to fire. That's why VA time is not fixed. Usually it is a change by each cycle length. So fixed VA interval exclude atrial tachycardia 100%. As this example, we can appreciate narrow complex tachycardia, long RB, with variable HA and variable VA. So the retrograde conduction, the VA time, it change with each cycle length. So it is not AV-NRT, not AVRT, and the atrial tachycardia is likely. Now let's go to the last golden rule in our lecture today with one of the eminent of electrophysiologists. Amazing law we have to know by Philip Comel. What did the notice that he told us about? The development of bundle branch block during SCVT associated with increase in VA interval more than 30 milliseconds and prolongation of tachycardia cycle length indicate and confirm the presence and participation of ipsilateral accessory pathway. Let's go to understand this concept in this example. At our right hand, we can assess and see narrow complex tachycardia with 1-to-1 conduction. It's a narrow complex, and we can appreciate septal VA 100 milliseconds and tachycardia cycle length 305 milliseconds. At the left side, the patient developed wide complex tachycardia, typical left bundle at V1, as we can see. What happened? VA time increased to 120 milliseconds and cycle length increased to 325. What does it mean? According to common law, it confirms 100% that patient developed typical left bundle, that he has ipsilateral left lateral accessory pathway, confirmed with increase in VA time from 100 to 120 and increase in cycle length from 305 to 325. And to understand the concept, let's look at the right side, in which the patient has narrow complex tachycardia, orthodromic. The impulse go down AV node and the retrograde accessory pathway, in which we can see the cycle length 305 and VA is short, about 100 milliseconds. We can understand this. At the left side, the patient developed sudden left bundle branch block in this orthodromic accessory pathway. So the impulse go down AV node, then take a long way. It reach through the right bundle, ventricular activation, retrograde accessory pathway, then atrium. So when the patient developed typical left bundle with left lateral accessory pathway, VA time increase as the way increased from ventricle to atrium, and cycle length increased to 325 in presence of typical left bundle wide complex tachycardia. Let's go to amazing golden rule related to this concept as well, which is in case of accessory pathway. And I know the patient has left lateral accessory pathway, for example, and he developed increase in VA more than 30 milliseconds. So if the patient developed ipsilateral left bundle branch block during tachycardia and the VA increase, it means the accessory pathway and the left bundle in the same side. On the other hand, if the patient has left lateral accessory pathway and contralateral right bundle branch block, the VA time will not change, it will be fixed. And to understand this again, this is on the left panel, orthodromic accessory pathway, impulse go antegrade AV node, retrograde through the left bundle, and then accessory pathway, then atrium. So if this patient has right bundle branch block in the middle panel, what will happen in VA and cycle length? Nothing, because the impulse will go antegrade AV node, then left bundle, and retrograde accessory pathway. No change at all. On the right panel, we can appreciate left bundle block, so the impulse will go down AV node, his bundle, then take very long way, right bundle, ventricle, retrograde accessory pathway, and increase in VA time and tachycardia cycle length. This is the example orthodromic accessory pathway, typical left bundle, left lateral accessory pathway as earliest A at CS 1-2 and VA time 110. When this patient with the left accessory pathway developed the right bundle, we find the VA interval still 110 millisecond. However, in the right bundle, the patient developed typical left bundle. What happened to the cycle length and the VA time? Dramatically increased. VA increased from 110 to 148, confirming the patient has typical left bundle branch block with left lateral accessory pathway. So let's summarize the feature of SVT in 6 points. As we know, there is typical features of rainbow. So our relationship between ventricle and atrium, is it one-to-one conduction or not? Number 2, atrial activation sequence, is it concentric or eccentric? Number 3, interval of VA, long VA or short VA, less than 70 or more than 70 millisecond. B, bundle branch block, ipsilateral with the accessory pathway associated with VA time increase more than 30 millisecond or not, to rule in accessory pathway. Number 5, onset and termination of tachycardia. As we mentioned, termination of tachycardia with A exclude atrial tach 100%. Last one, wobble, W, wobble of tachycardia, a change of intervals to know HH precede AA or not, to know is it His dependent, so AVNRT or accessory pathway mediated tachycardia. These are the 6 features of SVT. And to summarize all our lecture in one slide, it is Venhosen et al. Amazing paper. This is the most golden rule in our lecture today that summarize the 6 points in less than 1 minute. Let's see the 6 features of SVT. Number 1, VA relationship. V equal A, maybe AVNRT, AVRT, atrial tach. V more than A, it may be orthodromic, nodovascular, nodoventricular accessory pathway, or AVNRT with upper common pathway block, or junctional. If A more than V, it may be atrial tach or flutter, or AVNRT with lower common pathway block. VA interval more than 70, atypical AVNRT, atrial tach, AVRT, long RB tachycardia. But if it is, this is short RB. If it is short RB but VA less than 70, likely typical AVNRT. In case of long RB tachycardia, you have to search about atrial tach as a common scenario. Activation sequence, concentric, AVNRT, septal accessory pathway, atrial tach, eccentric, AVRT is likely. Termination with A, let atrial tach is unlikely. Number 5, HH change, precede, predict AAA, it means it is His dependent AVNRT or AVRT. VA increase more than 30 millisecond with functional ipsilateral bundle branch block, it means it's AVRT using free wall accessory pathway ipsilateral to bundle branch block. We are done with our lecture, but don't forget in the last slide to use IV adenosine if you are not able to reach your diagnosis. So termination and use adenosine to terminate tachycardia and see the response I want to highlight. If it's gradual slowing and reacceleration of tachycardia, it's autonomic, maybe sinus tach or autonomic focal or junctional tach. If it is sudden termination after adenosine, maybe AVNRT or accessory pathway. If it's persisting atrial tachycardia with transient high-grade AV block, micro re-entry focal atrial tachycardia or flutter are likely, and these are examples in which we give adenosine. In case of AVNRT, sudden termination back to sinus. In orthodromic AVRT, sudden termination back to sinus. In atrial tach or flutter, there is persistent atrial tach with BBB waves, then 1 QRS complex. So it's high grade AV block. Same in flutter, we can see more obvious flutter waves than termination. Now we are done with our lecture today. Thank you so much.